Good evening, everyone, and thank you for joining us tonight. I'm Sharon Mertzleft, and I'm a member of the St. Luke's team, joined this evening with several of my St. Luke's colleagues to present our program. I think everyone here tonight knows that February is American Heart Month. And clearly that's a time each year when our nation shines a spotlight on the importance of heart health, measures to help prevent heart disease, the need for more research, and efforts to ensure that we live longer and healthier lives. Let me say that while February is Heart Month, every day is Heart Day here at St. Luke's Hospital. And if you didn't know it before you came to tonight's program, you are in exactly the right place to learn about heart care and heart health. St. Luke's Heart and Vascular Institute offers a full range of state-of-the-art diagnostic, interventional, and surgical cardiac procedures. Our care is consistently recognized at regional and national levels for excellence in quality, safety, and patient experience. In fact, St. Luke's is the only hospital in the state of Missouri to be recognized for 12 years in a row by Healthgrades for outstanding patient experience. And this is a distinction that puts us in the top 5% of hospitals across the nation. Now, specific in terms of honors and awards for our heart and vascular care, St. Luke's is the Greater St. Louis region's exclusive alliance provider for the Cleveland Clinic Heart and Vascular Institute. And the Cleveland Clinic Heart and Vascular Institute is ranked #1 in the nation for heart care by U.S. News and World Report since 1995. So the other connection of our heart care services with U.S. News and National Report is that we've been recognized in 13 types of care at high levels of excellence by U.S. News. Within heart specifically, we've received the Cardiac Surgery Excellence Award from Healthgrades, as well as Healthgrades Coronary Intervention Excellence Award. We're among America's 100 best hospitals for coronary intervention and America's 50 best hospitals for cardiac surgery. I'm just going to brag for one more minute. In addition, our Heart and Vascular Institute has received the top rating, which is 3 stars, from the Society of Thoracic Surgeons. And this is a benchmarking tool that tracks patient safety and outcomes related to the TAVR procedure. The 3 out of 3 star rating places us among the top 8% of hospitals across the country to receive this rating. So in case all those awards and sharing them with you didn't get the point across, we are very proud of the amazing team on the stage tonight, the amazing team of about 4,800 additional St. Luke's team members whose work every day makes this outstanding care possible and carries out our mission to improve the health of the community. So why did we call this event or title it in terms of history? Well, it is said that history teaches us about the present. History helps us to understand how events and activities of the past have influenced the circumstances of today. So our program this evening, History Time, will help us understand why our health history is so important to our heart health today and in the future. So our panel of speakers, which I'll introduce in just a minute, will answer the question, what is heart disease? And they'll talk about the risk factors for the disease, what to do in case of an emergency, as well as the heart care resources and services that we provide here at St. Luke's. So now it's my pleasure to introduce those who will be leading the program this evening. Dr. Craig Reiss is the Chief of Cardiology Services at St. Luke's. He is board certified in cardiology as well as internal medicine. Mary Randazzo, seated next to Dr. Reiss, is a registered nurse and the manager of St. Luke's Cardiovascular Service Line's data and quality. Next, we have Amy Holtzclaw, and Amy is a certified clinical exercise physiologist. Amy is a certified clinical exercise physiologist, and she is the manager of our cardiac rehab program and our fitness programs. Emily Hafner is a certified registered dietitian and certified diabetes care specialist with our Nutrition, Wellness, and Diabetes Center. Let me say that all of these individuals have far more certifications after their name than I have or can ever hope to achieve in my career. Leading our program tonight is Glorice Zenos, who is a registered dietitian, certified diabetes educator, wellness coordinator for St. Luke's Community Outreach, an enthusiast for all things St. Luke's. She has the highest energy level of just about anyone I know. So again, thank you for joining us tonight. Thank you for your trust in St. Luke's. It is our pleasure to care for you. And I turn things over to Glorice.
I'm also very, very short, and they have a stool for short people like me. So thank you, everybody, for coming out today to join us live and also virtual. This session will be recorded and available for viewing in a later time. We're going to start with Dr. Reiss giving us a little bit of a background on why is it so important to spend some time regarding your medical history, particularly as it pertains to family history. Thank you.
Thank you. Thank you, and also thank you, Sharon, and welcome everyone here. It's always a pleasure to see patients and people that come out that are interested in heart disease to be proactive in their own care and in their family's care. So thank you, everyone, for joining us, both virtually and in person, and thank you for everybody on the panel. The first thing really that I'd like to look at, I have to get up and walk, okay? All right, so the first thing is really, we're talking about history. So medical history, okay? So when we talk about medical history and you see your physician or your provider, they'll be going through typical things. Now, one thing that I'd like to talk about in particular is the real importance of family history of heart disease, of cardiovascular disease. When we talk about family history for cardiovascular disease, it's really important to know who in the family has been affected. Any first-degree relatives that have had heart disease, people that have had coronary artery disease, stents, angina, bypass surgery, before something I said. I was about to get ejected off the stage. Before the age of 65 in particular. People in the family that died suddenly. A lot of times someone will say, someone in my family had a massive heart attack and they died. You go into the history and we find out that what happened was the person had sudden death. Sudden death doesn't necessarily mean a heart attack. Sudden death could be a serious problem from a heart arrhythmia or from a disease of the heart muscle itself. So taking an excellent history about the family history is important. There's some of our patients that when we see them and we're worried about some inherited disease or a problem of a heart rhythm, that the family history will be, oh, so-and-so died in a car accident. Finding out the particulars of that history, of that car accident, did the person drive off the road? Was that sudden death? Is very, very important. So both for coronary artery disease, but also for other serious heart rhythm disturbances are things called cardiomyopathies, diseases of the heart muscle. We're finding more and more and now can measure many different genes that can lead to early death, early heart disease. One of the other things that's important when somebody has an early family of heart disease was it somebody that, for instance, a parent passed away at the age of 65, they were diabetic, they were a big-time smoker for many, many years, and now they're coming in with heart disease, or was it somebody that everybody in the family who are non-smokers passed away from heart disease at a very young age? It has different implications for what we're going to do for diagnostic testing, both on blood testing, genetic testing, and what we'll see is some really cool other testing that now we can do with advanced imaging that we couldn't do even 5 years ago. Obviously, the medications are important and the usual things, but really family history is very, very important when we are seeing our patients for the first time. Symptoms of heart disease. When we talk about blocked arteries, one of the things that I tell my residents, my fellows, and other physicians is that never ask a patient about chest pain. Okay, most people that have heart disease, that have blocked arteries, won't tell you they're having chest pain. So my residents may come in and they'll say, nothing's wrong with this patient. I don't understand why they were in the hospital. And then I'll walk in and within about 30 seconds, we'll say the person needs a heart catheterization. They say, what's going on? You know, because when you ask patients whether or not they are having chest pain, most patients don't have chest pain. So the word that I always use is chest discomfort. Is somebody experiencing something that's not right in their chest with activity, in particular, if it's a stable blockage, or at rest, if it's a very tight blockage, it could be leading to heart attack. The discomfort may radiate into the arms, may go into the jaw, may go into the neck. it may be associated with shortness of breath. In some of our patients, shortness of breath is the only symptom. They don't have chest discomfort. Particularly in our patients with diabetes, as many as 40% or more of our patients can have heart attacks and not feel really anything, which is frightening, okay? So it's really important to be in tune. And shortness of breath is one of those things that can gear us into the thinking, and our patients should be aware of. If they used to be able to run up a flight of stairs with no problem, if they could walk a mile without a difficulty, now they're having to stop. That is an important potential history that we need to know about. Beware of indigestion. Many patients will say, I don't have anything going on. I just have heartburn. For years, because of advertisement and the wealth that is in the industry, in the pharmaceutical industry, in treating indigestion and heartburn, patients were focused on heartburn. Well, it turns out that a lot of this indigestion was the indigestion every time they ate a meal and walked. Was it when they were going up a flight of stairs? Is it indigestion when they were on the treadmill? That's not indigestion. I've cured a lot of indigestion with coronary stents, okay? There's also been, unfortunately, many stories of even physicians that were found with sudden death and with a bottle of Mylanta or something, whatever they use these days, next to them, of ignoring symptoms, thinking that it was indigestion or GI, when really it was the heart. Palpitations, especially if you feel lightheaded with the palpitations. A lot of patients have palpitations. I have palpitations. So palpitations are extra heartbeats that can be entirely normal, or it can be the marker of something that could be serious. So being able to sort that out is important when you speak with a physician to talk about extra heartbeats. We already mentioned shortness of breath with exercise, shortness of breath when you're lying down. Sudden swelling of your legs that's new could be a sign also of heart disease. So what is heart disease? Heart disease is a basket term for many, many things. I had somebody, I'm almost embarrassed to say, they had some medical training and they said, is it really hard to be a cardiologist? Either the heart is working or it's not working. Anyway, I still talk to him. He's still a friend. But we educated him a bit about the things. So heart disease or cardiovascular disease is a basket term for many, many different things. The most common and the thing that we really want to address primarily is coronary heart disease. So atherosclerosis of the blood vessels that supply the heart. Overall, the #1 killer in our country, both women and men. So coronary artery disease is the most important thing. But it also involves congestive heart failure. I hate that term, okay? Because it sounds like you got no chance of success, okay? But really, with congestive heart failure, it's either the heart is too weak and there can be fluid buildup and backup, or it can be that the heart is actually strong, but it is stiff in the way that it's relaxing, and there can be a backup of fluid. And we have many, many new treatments for heart disease. We actually have a heart failure expert now at St. Luke's Hospital who was at Barnes for many years. His name is Shane LaRue, that has a heart failure clinic. And we have many drugs that are really exploded in heart failure over the last 5 years. It has revolutionized our treatment of both what we call heart failure with reduced ejection fraction, which is a weakened heart, and also heart failure with preserved ejection fraction, which is a strong heart, but where people have backup of fluid. In addition, heart rhythm disturbances and other disturbances are here. So atrial fibrillation. Atrial fibrillation is also a disease that has dramatically changed in how we manage over the last 10 years. So for people that have atrial fibrillation, we now have ablation procedures, which are extremely effective, and we're becoming much faster at being able to do them. They're becoming first-line treatment in a lot of our patients, where before it was a last resort of what we did. And we also have a very active electrophysiology program, and I think we are the best in the city. I would put my back behind that and say yes. Okay. In addition, valvular heart disease. So valvular heart disease is also very important, and it can lead to heart failure. We mentioned the TAVR program. I believe we're the only 3-star in the region in TAVR. We did our 500th case around 4 or 5 months ago, and very low complication risk. If you would have told me 15 years ago that we're going to be able to replace an aortic valve without surgery, I would have said, I want whatever you're taking, okay? Good drugs, okay? But now this is routine. We can also repair the mitral valve, done without an operation. Totally revolutionary and very important in changing lives. I've had 95-year-olds, 96, that have had a aortic valve replaced and gone home within 48 hours or 24 hours. Amazing technology. So when we talk about what leads to cardiovascular disease and what leads to strokes, what leads to heart attacks, it's a process that takes a long time to develop. This is a blood vessel in cross-section. And the blood vessel in cross-section has different layers, and LDL cholesterol is deposited into the blood vessel lining or the endothelium, and it starts, unfortunately, at very young ages. It can start in our teens. In the Korean War, when unfortunately young soldiers were killed, there was the evidence that in the age of 18, 19-year-olds, there's a start of atherosclerotic streaking with typical Western diets, unfortunately. And our dietitian will tell us what we need to do different. As time goes on, we then get more complex plaque that begins to build up. And this is called a lipid-rich core, and you get more and more cholesterol that is deposited. As this begins to happen, you get a compromise of the blood vessel lumen, where the blood vessel becomes a little smaller and a little smaller and a little smaller. As time goes on, there's also going to be inflammation that begins to occur within the lipid-rich core. I like to explain what happens somewhat like a volcano to my patients. What do I mean by that? I mean that if you think about it, a volcano that has not erupted, it looks like a pretty innocent thing. Okay, get a little mountain that's sort of there, but underneath the surface is magma. If that magma gets to the surface, that's when all problems start. So what can happen is that this fibrous cap, through inflammation, can then begin to develop a weakness, and eventually what can happen over the decades is that, again, this is, again, in people in their 20s and 30s and 40s, and then they begin to get a problem with the buildup of lipids, and then all of a sudden, this even looks like a volcano, doesn't it? Okay? So all of a sudden now, this ruptures. It's called a plaque rupture. When that molten lipid-rich core comes to the surface, then blood clots on top of here, the body says, uh-oh, I got to stop that. And when you get then to this phase, that we're starting to begin to have compromise of blood flow to what other vessel we're talking about. But in addition, if you get a blood clot on top of that and you totally occlude flow, that's a heart attack. That's a myocardial infarction. So it depends on where that blood vessel is as to what the end result is. If what I just showed you is in the carotid artery, that this is a stroke that can happen, or a transient ischemic attack. Some of those also come from the heart, okay? I always tell my residents the heart's the most important organ in the body. Okay, so, and then somebody else in the audience always says, no, it's the brain. So the problem is that when it gets to the blood vessels up here in the neck, it then causes essentially a heart attack of the brain, which is a stroke. Then, if it's in the blood vessels of the heart, it causes either angina, if the volcano hasn't totally erupted and now we have a mountain that's there, so that's chest discomfort with activity. But if all of a sudden there's an eruption and you totally occlude blood flow, that is a heart attack. If it happens in the legs, and we typically see this in our patients with diabetes, but most importantly are cigarette smokers, then you can have problems with blood flow to the leg that can cause pain in the leg called claudication when you exert yourself, or can even cause life-threatening limb ischemia where you actually can lose a leg if you don't seek help, and have revascularization where they reestablish blood flow to the leg. Now cool stuff, okay? So what's happened over the last 5 or 6 years is a revolution in how we are imaging the heart. So what do I mean by that? I mean that I'm practicing cardiology entirely different than I trained for decades. And it was very clear that we were going to be having with our new technologies, new ways of diagnosing heart disease. And it was really one of my goals as chief of cardiology to try to make St. Luke's a true leader in imaging of the heart, our advanced cardiac imaging. So we hired 2 people over the last 5 years. One was trained at Harvard. There was an expert in cardiac imaging, and another that now heads our division was the director at Rush in Chicago, and actually is the national director of cardiac MRI, and she trained at the NIH in what's called CT angiography. So CT angiography is really state of the art, and we have it here at St. Luke's. This is a case that I just wanted to show you, and again, these are just sort of pictures to say, wow, can we bring down the lights a little bit in the front perhaps? So this was a patient that was seen at St. Luke's by one of my colleagues. He had had a treadmill stress test, and he was having exertional chest discomfort. Did a treadmill stress test. Anybody here, somebody who had a treadmill stress test, and you hear, God forbid, they go out and they pass away? They passed it? Unfortunately, it happens. Turns out that a routine treadmill stress test, you want to know how often we pick up a problem if it's there? 60% of the time. General stress testing that we do, like a stress echo, 75% of the time. Routine nuclear stress testing, which is what most institutions do, 80% of the time. The American Heart Association, the American College of Cardiology, within the last year, finally now has raised CT angiography to a class 1 indication, which is the first thing that we can do in our patients that have what we say is intermediate risk factors and concerning history. This is a patient that underwent a treadmill stress test. It was normal. Saw the cardiologist, said, I don't like this history. So it would turn out that 10 years ago, we would have sent the patient for an invasive cardiac catheterization right away. And a lot of times when we do it, we find there's nothing there. So we put somebody through an invasive test that wasn't necessary with potential complications. What happened here was that the person had a CT of the arteries of the heart, and this is the important blood vessel that comes down the front of the heart, which is the left anterior descending, also called the widowmaker. Okay? Critical artery that supplies the heart. And what we see, and you have to take my word for it. Okay? See how it's nice and white here, but right here it's not. Okay? Right over here, it's nice and white, and now it's not. Okay? And in the blood vessel here, now it's not. Okay, if we look at it in cross-section here, we see a dropout. This, we're worried now, is a very tight blockage in the widowmaker in a person that had a normal stress test. The person, the back of the heart is here. These are 2 other arteries. These arteries aren't so bad. Okay, that's what a normal artery looks like here, and the circumflex goes around the side of the heart. These are the pictures we can now look at of the arteries of the heart done non-invasively. This person then went to a heart catheterization, normal stress test, remember? This is the most important artery of their heart, the widowmaker, hanging by a thread. Okay, found by the test done at St. Luke's. And here we see, after stent, a totally normal artery. Moving pictures, same thing, same patient. Okay, again, critical blockage in the artery supplying the heart here. The left anterior descending, and afterwards the stent has now restored blood flow. That would have been a life-threatening circumstance. Okay. This is another patient that, again, this patient had had normal stress testing and ended up having a blockage in several of the arteries supplying the heart. So you can see right here, a very tight blockage. Look at this, isn't this neat? Okay. So in stress testing, we're looking at what an EKG looks like. We're looking at what nuclear medicine looks like that's being injected to the heart, things like that. Here we're looking at the artery itself. And here's the person that then went through the procedure, and you can see that this person had a very bad blockage in this artery here that was picked up by CT angiography. And this is the Widowmaker again, a very tight blockage, and both of these were repaired. This is another study that was done, and again, we see that there's a problem in this blood vessel right here, where this is called a high-risk plaque. So calcified plaques are not as bothersome as soft plaque. And this person had a high-risk plaque. This is a very interesting technique where we send our pictures actually to a place out of Stanford where they do flow dynamics. And we can actually determine very accurately whether or not there is compromise to blood flow using computer modeling of the blood flow to the heart. Anything less than 0.8 is significant, and we get this back within about 4 to 6 hours after we do our studies. Here's another case just to sort of show you what it looks like, where this one does not have severe disease in this. This is all calcification of the blood vessels. Calcification of the blood vessel. But right here, there's a tight blockage. Another test, so that was CT angiography, very, very exciting. Okay, we have the state-of-the-art scanner, which is called the Force. It has much less radiation exposure than routine CT scans, and we get pictures that are gorgeous like this. We have another technique that we were the first also in the region to offer on a routine basis, and this is stress PET scanning. So stress PET scanning, remember I told you routine treadmill stress testing 60%, stress echo 75% accurate, nuclear stress testing 80%, stress PET scanning 92% accurate, okay? And what the stress PET scan does is it uses a different radioisotope that goes away in a hurry, but emits a lot of radiation in a hurry. What it ends up doing, though, is because it goes away quickly, it has about 75% less radiation than a routine stress test. It gives us much better pictures. We can also figure out, believe it or not, the flow down each blood vessel. We can look for calcium in the blood vessel, and we can look at how well the heart is squeezing. We can also get the entire test done in 30 minutes. If anybody here has had a routine nuclear stress test that takes 3 to 4 hours, okay, this can be done in 30 to 40 minutes. And we already said much less in patients that are obese or in women, which sometimes because of breast tissue can cause abnormal images of the heart when we do nuclear medicine, the stress PET scan has no effect. So we can do this in people that are very obese. We can do this in women. We can do this very accurately in all our patients. And this is a case that took place that this is basically what a routine treadmill, what a routine nuclear spec study looks like. And it actually looked like it was really very abnormal. This is a stress PET scan, and all of this was artifact, and we see gorgeous pictures and totally normal study. One other cool imaging technique that we have in cardiology right now is cardiac MRI. Cardiac MRI gives us amazing pictures of the heart, and we can make a lot of diagnoses of different people that have weakened heart muscles, thickened heart muscles, or valvular heart disease. This is just, I want to show you how cool this is, okay? So this is a moving picture of the heart. One of the things that can be seen is whether or not there's scar tissue within the heart. So right over here, we can see there's actually scar tissue in the heart. And that's where we are.
Okay. Wow. I have to say that was pretty cool, Dr. Reiss. I think we all learned something new after that presentation, right? Before we take some questions, I just wanted to touch base on risk factors for heart disease. I know you're familiar with them, but in this case, I'm going to bring a part of the questions that were submitted by our audience, and I'm going to loop in our exercise physiologist. Amy, what is the best exercise for sound heart health?
Jumping right in. So it's a bit of a trick question because ideally the best exercise is aerobic. You know, it's some form of walking, biking, swimming, you know, whatever you like to do. And I think that's really important is it has to be something that you enjoy doing. So if I say, hey, the best exercise is running, but you hate running, you're probably not going to do it. So you got to find something that you like to do. The whole goal really is to be as physically active as you can. So the general guidelines for ultimate heart health is at least 150 minutes of exercise per week. So generally we'll say, you know, try to go for 30 minutes, 5 days a week, like do some sort of aerobic activity. So it has to be something that you're constantly doing for 30 minutes. So like housework doesn't count. Gardening doesn't count because there's too many starts and stops. So it could be as easy as just going for a walk. As far as intensity, you want it to be moderate. So think of a lot of what we tell our patients is you could talk, but you can't sing. So you know that you have to breathe a little bit harder, but so you can't have a normal conversation, but you could still talk. Does that make sense? Okay.
And we're going to put a little plug. If you do have a history of heart disease, it's always best to exercise safely. So have a doctor's order and exercise like at St. Luke's Fitness Center where you feel safe and you have access there. Emily, do you want to do a word here on nutrition and diet? Because when we talk about risk factors, there are those that we cannot modify, that we spoke of age, we spoke of family history, and some of what comes in with congenital. And we talk about lifestyle modification, the earlier, the better, with healthy living, diet, exercise, sleep, and hopefully no much smoking cessation, tobacco. But when it comes to diet, what are your most common tips for a heart-healthy diet?
Sure. So I think one of the biggest things that I think working with younger patients, and I say that as a relatively young person, is that cardiovascular disease does take years to develop. So for someone in their 20s, 30s who may not even regularly see a physician and their diet is not necessarily heart healthy, it's something that I'm already encouraging. So I consider generally heart healthy as something that is not going to promote inflammation. A lot of these like long-term conditions, especially heart disease, it's an inflammatory response, right? So we want to keep meeting your nutritional needs as a focus, including foods that reduce inflammation. So these would be our healthy fats. So that would include things like olive oils, nuts, and seeds. Fattier fish, which would be salmon, tuna, mackerel, herring, healthy oils, olive oils, olives themselves, avocados. So some healthy oils and modified sugar intake. We do know that overall with nutrition, high sugar intake and red meats promote inflammation. So it's kind of two categories that in general I kind of focus on to keep the inflammation low. And then just general animal products. It's a long-term debate with nutrition, and it's ever evolving. But in general, your protein sources, just really focusing on quality. I think we get lost on how many eggs. can I drink milk? There's so many milks. And I'm like, let's just get down to basics. So lean proteins, your chicken, your turkeys, white fish, fatty fish. And I think just quality nutrition is the best to promote good heart health.
Very good. The earlier the better, but it's never too late to treat your body nicely
Never.
with good
Come
food.
see me.
That's right. Okay, and next I'm going to give the space, the audience stage for Mary. She's our nurse on cardiology, and one of the most important things as the doctor started is recognizing the signs and symptoms of a cardiac episode. So Mary, can you talk a little bit about the BFAST acronym, please?
Oh, sure. I think what Glorice said is accurate. It's identification and then what you do next. Those are two extremely important things that will change the course of getting the care that you need. And for stroke, we use the acronym BFAST. It used to just be FAST, and they added the BE before that. And the B stands for balance. These are sudden onset of symptoms that are really not explained by anything else. The sudden loss of balance is usually one-sided. People are walking to one side. It's just an alarming symptom that you would notice. Eyes is a vision, and it's one-sided most of the time. It's a visual, like if you think of a clock, and all of a sudden you can't see from 12 to 6 on that side. That's a visual field loss, and that's a very alarming symptom. So that's what the E stands for. Face, I think, is what we all kind of consider stroke-like symptoms, where you have paralysis and on one side of your face, and it's very obvious, along with the arms and the legs, where it's one side, you have weakness on one side of your body. I think that's a pretty standard symbol of a stroke that we're all familiar with. Speech is, if you are having trouble speaking, sometimes it's confusion, not all the time just confusion, because there's other reasons that people's speech is confused. But the speech symptom for stroke is where people are seriously having trouble making the words, and you can tell they want to say something and they can't get the words out. And then the T stands for time, which is critical for both stroke and heart attack identification, to act with those symptoms. Those alarming symptoms, you're worried, the next thing you do is to call 911. So for stroke, it's BFAST. For cardiology and on heart symptoms, it's many of the things Dr. Reiss was talking about, where there's a reason you're having those symptoms. Your heart is struggling. When there's an interruption of blood flow to your heart or to your brain, you're going to get a symptom. Sometimes. There are some people that don't get any symptoms, and that's really scary, but commonly you do. And it's discomfort in your chest, the unexplained shortness of breath. If you are feeling something that just isn't right and you doesn't make sense in any other way, a discomfort in your chest coupled with some nausea, maybe some sweating, lightheadedness, that's something you should pay attention to. And the most important thing is what you do next, which is call 911. They have the resources, they know capabilities of the closest hospital, they can get you there faster. They can also treat you en route. And one of the things that we have done in our program here is the activation of our teams and our physicians. All of the resources we have here, EMS can alert us that they have a patient that's being brought in with those symptoms, and we get a heads up. And in off hours and other times, that's a very critical aspect of what we do, so that the team is on their way while you're on your way. That's an important part of calling 911, so they can diagnose you, treat you, and alert the receiving facility for what's coming.
And what we do, and Mary's our coordinator for this, is being a a heart attack center is that 24/7, it's our goal, and we achieve that goal incredibly, way over 90% of the time, is once some person comes in, we get that blood vessel open within 60 minutes of arrival. And that's from the moment they hit the door until we actually take them right to the catheterization laboratory and open up that blood vessel. And our rule is that everybody has to get here in cardiology 24/7 within 30 minutes of getting that phone call from the emergency room. And a lot of times it's pre-activation, where the EMS will call and say, we're bringing in a heart attack, and we immediately activate, and our doctors will be waiting for the patient when they get there, coming home 24/7.
Right, we have a good relationship with the EMS in our region, as do many hospitals. So you're safe in a lot of areas in the city, where the EMS, we take their word when they can identify somebody having a stroke or a heart attack. And we don't question that. We don't make them prove it by sending an EKG or anything like that. They say they have somebody coming in with these symptoms, and they're having a heart attack. We activate our team. They're on their way in when you're on your way here. And we've had not only door to balloon time, which is what we absolutely monitor all the time, but we actually had what they call a first medical contact, which is when that EMS is at your side in your home to a balloon in January of 68 minutes. So in 68 minutes from the time EMS was at this patient's side to when they were in our catheterization lab with a balloon across a blocked artery like you saw in those pictures was 68 minutes. And that's a great process that we're proud of. I think that that's what people deserve, and we're always happy to be able to say things like that.
And it's also the important thing to recognize for both stroke and heart attack is that every minute that there is pain going on or stroke symptoms, the tissue behind where that blockage is dying. That's heart muscle, that's brain. So the job is that we are to open up those blood vessels as quickly as possible to stop the damage that could happen. So that's why recognizing the symptoms and getting medical assistance immediately makes not only a difference how somebody does for the next week, the next few days, for the rest of their life, they're affected by having that immediate care. Because if there's damage to the heart muscle, there's damage to the brain, that we can see improvement with the appropriate rehab, it still is much, much better if you get that blood vessel open immediately and have minimal damage.
So in case of an emergency, what do you need to do? You call 911. So either if you or someone you love, you suspect they're having a cardiac issue, don't drive. Call 911. If you have risk factors such as the ones that we mentioned earlier, and I like to emphasize, age is non-modifiable, family history is non-modifiable. If you're aware of those, be very, very conscious of calling 911 right away so you can enact this process. One of the things that my video is unavailable is the concept of hands-on CPR only. About 90% of people that have a cardiac arrest will not be in the hospital. It's outside of the home, and the likelihood of survival is very poor. So if you can call 911 and do hard and fast chest compressions, I'm not going to sing the Bee Gees song, but you know which one I'm talking about, you can really enhance the likelihood of survival for that individual. I'm going to be sharing with you the link for watching this video, and also if you want to get further training on hands-on only CPR.
One other important point is with age, is that unfortunately heart attacks also happen in young people. So that because somebody is 30, 40, 50 years old doesn't mean they couldn't be having a heart attack. So that we do see, unfortunately, I have more patients that I can count that are less than 40 that have heart attacks. Young women after pregnancy can develop a certain kind of a heart attack, for instance, or during pregnancy. In addition to younger patients, and again, I've had And then last week, probably 2 patients, one was 28 and the other was mid-30s. They were males that had heart attacks at young ages. So again, even though you're more likely to have a heart attack as you get older, if you're having the symptoms, do not ignore it. And we have way too many patients who show up in our emergency room with heart attacks that are being driven to the hospital. And that is an automatic delay. And again, a lot of probably men more than women say, I don't really need to go to the hospital. It's probably indigestion, right? And it's usually the wife that says, get to the hospital and call 911 is the most important message.
I'm going to do a shout out for the ladies too, because women are caregivers by nature and they endure a lot, and sometimes don't do very well because we delay seeking care. So pay attention to you above all things before caring for others. Sometimes is a good too.
And that women do delay more than men frequently, because there's been a false belief for many, many years that heart disease is a disease of men. And again, it's the #1 killer of women.
Clarice, if you want to go ahead and try, just click watch the video.
Okay.
We seem to think it will work for you. It's a really short one. Is that going to work?
I'm going to try one more time. If not, we're going to...
No worries if not. We can send it out in the link.
Yeah. Should I pray this? No, it's actually a pretty cool video, but you'll see it tomorrow.
Okay.
Oh, did it go? No, it didn't want to.
No problem.
Okay.
I was going to say, we have lots of questions up there. I think you still have some there. And if I could ask the speakers when you're speaking to please pull the microphone a little closer to you. Thank you.
Okay, so we're going to give questions to the audience that's present here, and I also have some questions that have been submitted ahead, and I'm assuming Dawn from the chat box. So if you raise your hand, please, if you have a question right now. If not, I'm going to read one from the ones that I have. Yes, ma'am?
So with the chest discomfort, how do you know if it's heart if you have asthma?
So with chest discomfort, how do you know if it's hard or if you have asthma? How to tell the difference?
Sometimes it's very hard to know. And in general, you need a physician to help to figure that out. I give a few pearls to my patients in that, in general, chest discomfort that's coming from the heart very rarely lasts less than 30 seconds. So if somebody has, just a pain, just a pain. Okay, or I walked in, just a pain. That flirting little discomfort rarely is the heart. In general, an anginal discomfort, a heart discomfort lasts for longer than 30 seconds. However, with asthma, you can have an uncomfortable feeling in the chest when you exert yourself or at rest. And it really takes a physician to be able to sort that out and never assume it's asthma if you have other risk factors, and it should be evaluated. And now, as you can see with our technology, we can figure it out. Okay?
I have a good one here. If someone is on statins, blood pressure medicine, and other heart medicines, and in the early 40s, what are the odds of coming off any of these drugs in her lifetime? And I want to add, even if you make lifestyle modifications, I want to say.
Well, again, statins, first of all, we heard an unpopular term of sort of bad press or false press or whatever press, okay? Statins have saved more lives than any other medicine ever. It prevents heart attacks, it prevents strokes. The serious side effect is far less than 5% of patients having to stop it. Statins have been proven unequivocally to stop and prevent heart attacks and to prevent second heart attacks. So, if the person was placed on a statin appropriately, the likelihood is they need to stay on a statin. There are other medications that we have that have been developed that we have become very good at using for people that do have statin intolerance, or we don't get to the goal of where we really want. We want very low cholesterols in our patients. Once they have established blockages like we're seeing on the images, we want the LDL cholesterol less than 70. In a subgroup, sometimes less than 60. So sometimes the statins alone don't work, or we get to a higher dose and they are having side effects. We now have injectable drugs that we use very frequently, twice a month injectables. Believe it or not, we now have an injectable that is twice a year that is administered, that has tremendous effects on lowering cholesterols. These are non-statin drugs, and there are other agents in addition. So the likelihood is that at least the cholesterol medications they will remain on, because we know the tremendous benefit of the statin drugs. As far as the antihypertensives and others, again, it depends on each person. If they make major lifestyle modifications, if they're doing the exercise, the diet, if it was somebody that, was 40 pounds overweight and wasn't exercising. I have some great pictures of one of my patients that presented with heart disease in his 20s. He lost 100 pounds, he became a vegan, and he came off of almost all of his medications, though he still is on a statin. So again, you can make some dramatic lifestyle changes, but the antihypertensives and others can go away occasionally.
Good. Yes.
So, okay, I have low blood pressure usually, and inappropriate tachycardia. But I've noticed a lot of times I get short of breath when my heart rate goes up. But it's like if I'm leaning forward and my arms out, so could it be positional?
Sounds like a little complicated to answer the question without knowing your entire history and examining you. But in general, a cardiologist can go through that. And there is a condition called inappropriate sinus tachycardia, where the heart goes too fast. There are other autonomic dysfunction, where the nervous system doesn't regulate things appropriately. And believe it or not, there's a big incidence of this after COVID. We are seeing an increased incidence in this post-COVID in our population. So yes, there are conditions where it can cause discomfort or shortness of breath or changes in heart that are not blockages, but that has to be figured out, because you don't want to miss blockages, or you don't want to miss a weakness of the heart.
Right. So that would be how you figure it out, like if you got shortness of the breath after you had COVID versus you might be putting on some age.
Sometimes, yes.
You get it tested.
Yeah. Exactly. And again, it's the history, it's other things, how the COVID affected the person. But the autonomic dysfunction, there's something called POTS syndrome, or autonomic dysfunction is something that we see a little bit more frequently after COVID.
Okay, I have another good question. Please, I don't know who, maybe Mary can answer the difference between an ECG versus an EKG? Or maybe Doc, I don't know, I put you on the spot, Mary, just for fun.
There is no difference.
Okay, oh, that was an easy one. I was afraid to ask you.
EKG is an old German term for the way that you spell it, and ECG is the term that we use.
Oh, that was a good one. Okay, how about this one? How can we mitigate genetic predisposition to heart problems?
So it's another good question. So it all depends on what the genetic predisposition is. So if it's that everybody in the family had heart disease at a young age, you see the cardiologist, and the cardiologist then figures out, is this a familial elevation in cholesterol, for instance? Is it familial low HDL cholesterol? There is another lipoprotein, which I've had interest in for decades, which now is actually come to the forefront, and that is something called LP little a. And we're finding out that LP little a is something that runs in families and can cause early heart disease. And so there's a variety of different things. If we then find, for instance, that somebody has an elevation in LP little a, that we likely will have a medication within 3 or 4 years, we then will take that person and be very aggressive in dropping cholesterols to like LDLs less than 55, and really make big differences in what their likelihood is developing heart disease in the future. Putting them on appropriate blood pressure medicines, making sure they're doing exercise 30 minutes a day. I don't want to leave out the dietitian, of making sure that the diet is anti-inflammatory, Mediterranean type diet that they're following. All of these things can really change what was early heart disease, and we have many patients that I see every day, including today. I still have notes to dictate of patients that have early heart disease, and we are making these changes. And then doing the diagnostic testing that we talked about, in order to make sure that they don't have disease, and if they do, to then be able to act upon it before it's too late. Yes?
Regarding the genetics, if they're suspected, should the patient receive the testing or perhaps the non-symptomatic offspring?
Yes. Yeah, so it all depends on what we're talking about. Let's say it's somebody that has a weakness of the heart muscle or a thickened heart muscle, okay? So what we generally do is in patients that have these cardiomyopathies is we test the patient. Unfortunately, sometimes if patients have passed away, we'll actually ask for a genetic autopsy on the patient. And then we take that marker in our patient and then we tell siblings and children to get screened. We have genetic counselors that work with them through the genetic companies now, and then go from there. If it's, for instance, an Lp(a) that I just mentioned, that's not a genetic test, it's a blood test. But if we identify it in our patient, it's important in that patient to lower cholesterols, but it's also important to then measure it in offspring and also siblings so that they can get tested if appropriately and alter their risk factors. Yes?
Does the heart MRI detect any blockage in the artery?
MRI is not really technically for, with current technology, to look directly at the artery for blockage. There are, believe it or not, and we're going to be starting to do this, there are stress tests with MRI that also can look at perfusion of what's happening to the heart muscle. So it's indirectly. CT angiography is what detects whether or not there's actually blockages in the artery. MRI, we probably will have available within the next 6 to 12 months at St. Luke's for the stress testing. The only problem with MRI is if you've ever been in an MRI, it's not very fun, and then to have your heart racing in it or feel uncomfortable, it's a little bit less fun. CT angiography in general is what we promote a little bit more, though we will have that capability. The nice thing about MRI is it is without radiation. But again, the CT angiography with our current technology is very low radiation.
Is there a lot of radiation in the CT?
There's not in our CT scanner. It's, again, a special CT scanner. It's a Siemens Force CT scanner that has dual radiation source. So by having two different sources, if the thing goes really, really fast with two sources, it decreases the amount of radiation that's actually there. So the amount of radiation is much, much smaller than it was even 5 to 10 years ago.
Any questions, Dawn, from the online?
Yes, we have a couple, and I know we only have a couple minutes remaining before we hand out the gift cards. One of them is I have food sensitivities to wheat artificial sweeteners that I avoid due to using due to causing cardiac arrhythmia. Besides avoidance, how do I prevent any more rhythm trouble in the future?
So if I understand the question, the patient is contributing wheat and certain foods to arrhythmias?
Correct.
Interesting. I don't really...
I don't know either, so don't feel bad.
It's not a common, would I say, like, if I know someone has food sensitivities, would I be warning them about arrhythmias if I didn't know any history? Probably not. Am I not saying that that's valid? I'm not sure, Dr. Reiss, if you have an opinion on this?
I mean, some people do note, and it's hard to know. I never say never.
Yeah.
I can make up that potentially with wheat sensitivity, that you can have increased inflammation. Inflammation has been related to atrial fibrillation. It's possible, but I have to sort of jump through some hoops and wave my hands a little bit in order to really say for sure. But I never discount a patient that notices something that occurs, and avoiding it is the only way that I know to. The thing to avoid with most arrhythmias, believe it or not, is not caffeine. This is, it's actually alcohol. So alcohol, for instance, for atrial arrhythmias and ventricular arrhythmias, even 1 or 2 glasses a day for some patients is too much. We actually find that 2 or 3 cups of coffee a day probably helps arrhythmias. That's new over the last few years, and I really like that since I'm totally
Yeah, me too, what he said.
Also, it goes back to what know how your body feels, when you exposed to something that doesn't feel nice or feels well. Given the time, Dawn, do you want to do one more from the panel, or we should go ahead? We have some wonderful attendance prizes for you for taking out the time for coming out today and joining us.
Sure. I was just going to say, I can. You have the gift certificates down there with you. I know we have 2 gift certificates for personal training with Amy's group over in the therapy services department, and also for green bean delivery service. So Glorice, the first winner, she is online, and her name is Susan. So Susan, we will be contacting you. And what did she win, Glorice?
She won a personal trainer session.
Awesome. So Susan, we will be getting with you. The next winner we have is Veronica, and she is in the audience.
Veronica,
H.
you have won the green bean delivery service. Yay! And we have one more.
And the last is Vince L., and he is in the audience.
Vince, okay, personal trainer right here for you. Thank you so much for joining us. I will be sending you by email some of the content that we shared today and a lot of the resources. We hope to see you around. If you have any questions or if you would like assistance in navigating our healthcare system here at St. Luke's, at least we can help you out. You have a friend in us. And thank you so much for joining us tonight, and for those of you who join us online. Have a wonderful evening. Thank you.
Thank you.